Great. Welcome back to House Healthcare. We are changing now to H263, which is an act relating to emergency medical services. And we have Representative Catherine Sims here, who has done an amazing amount of work on this subject. She's the sponsor of the bill. And so she will probably take longer than we normally have sponsors coming in because she really has worked a lot on this. So I want to give her the time to explain what she's done and what she's learned. So it's all you.
Chair, Healthcare Committee, excited to be here with you this morning. Representative Catherine Sims from Orleans 4, and really appreciate the opportunity to talk with you all about H263, the EMS bill, which seeks to address some of the big challenges in our system around funding, regional coordination, and workforce development. I'm glad to be here to provide a high-level overview, and then really glad that you have a number of witnesses who are the boots on the ground doing this work and talk in more detail about the challenges that our EMS system faces and the next steps to address them. So as you all know, being the Healthcare Committee, EMS is a really critical part of our emergency response system and our healthcare system. And as a part of that system, our EMS professionals are providing critical access to life-saving procedures, medical transportation to a growing number of Vermonters. You know, I think we all expect an ambulance to come when you dial 911. But unfortunately, the EMS system in Vermont is in, no pun intended, critical condition in every part of our state. There's rising call volume. So EMS responders from our 79 ambulance services and 91 first response services answered in excess of 119,000 calls last year in 2022, which is a 12% increase over the 2019 numbers. So more calls at a time when there are staffing shortages. So in 2022, the overall turnover in EMS industry, is between 20 and 36% on an annual basis. So that's, really significant churn and challenges around finding staff and volunteers necessary. And in the midst of all that, there's underfunding and an increased cost of readiness. Again, whether you call EMS or not, they need to be ready 24 hours a day, 7 days a week. And there are, baseline costs that need to be covered in order to assure that readiness. And there's huge underfunding. Our EMS squads rely on towns for a portion of their budget. And a bulk of the revenue comes from reimbursement from insurance companies, mainly Medicaid and Medicare. And as you all know, and have heard extensive testimony across all areas, that those reimbursement rates, fall very short of the full cost of service. So, for example, the sort of, maximum reimbursement for an ambulance trip is $500 from Medicaid care. And Medicaid rates that are set by the state are even lower at $390 per trip. And if you talk to ambulance crews, they'll tell you that doesn't nearly cover the cost of the trip. It is in the public interest to provide available, coordinated, quality EMS services to individuals across the state. Given these underlying systemic challenges, this bill seeks to try to stabilize our EMS systems in a number of different ways. And I'll start by sharing that this bill comes from work with the Vermont League of Cities and Towns and our EMS service providers this summer and fall to really try to understand the challenges that communities face, and then look at what other states have done, especially other rural states who face similar challenges, because Vermont is not alone, you're not unique in these challenges, and puts forward a kind of omnibus, recommendation on a lot of different levels to address the funding, workforce, and coordination challenges. And so apologize for the length of this introduction, but we tried to do some due diligence to hear from stakeholders and look at what other states are doing and propose, some big ideas that, I hope will prompt lots more conversation by this committee. So the bill starts with an annual appropriation. And so that would be $20 million every year for the first 5 years from the general fund to stabilize EMS. And that would go to the Emergency Medical Services Special Fund and be used to reduce, and that appropriation would be reduced the maximum possible extent it could by maximizing reimbursements through existing structures. And that funding would be distributed to EMS districts to defray the cost of the unreimbursed transportation and non-transportation costs, the training and continued education for EMS providers, the purchase of medical equipment, and direct district administration costs. And so the purpose of that kind of, placeholder annual appropriation is to stabilize the system while we all work long-term to create a stable funding model for EMS. Second, the bill expands commercial insurance and Medicaid coverage for treatment without transportation. So right now, there are times when your EMS provider might respond to a call that doesn't require transportation to a hospital. So that might be administering medication to a diabetic. It might be a lift assist with a stroke assessment to determine the nature of the fall. All of those things are really important care, but right now are not typically covered by insurance companies. And I think important to recognize that delivering that care out of a hospital actually probably delivers a lot of important cost savings as well. And so we want to help get people care where they need it. So these sections of the bill would require an insurance company and Medicaid to cover reasonably necessary costs associated with providing treatment without transport. There is some ongoing conversation with DVHA about whether there is a code that currently covers that, and encourage the committee to dig into that. It sounds like at minimum maybe there's a lack of a definition around treatment, which is necessary to determine when that billing code can be used. The bill also looks at transportation to an alternative destination. So often when you call an ambulance, you need to go to a hospital, but not always. Sometimes an urgent care facility might be a better destination, or a mental health care facility. And this section would allow Medicaid to provide coverage for transportation services where the recipient agrees to an alternative destination being the right place, again, at reasonable and adequate reimbursement rates. The bill also includes language, which I think you have already considered and recommended to the Appropriations Committee, around increasing Medicaid reimbursement rates. Those rates were set in 2019 at 80% of Medicare rates, but there hasn't been no subsequent update. And so this bill recommends the 100% of Medicaid reimbursement rates with an annual inflator, so that we don't have to keep coming back every year to make those adjustments. And so thank you for your support for that already to the Appropriations Committee. We're almost there, 2 more sections. The next section would create an Emergency Medical Services Study Committee. And so this regional coordination study committee would assess the current EMS district structure and look at costs of service within those districts and how regional efforts might yield more efficient and more cost-effective service to all Vermonters. So the committee specifically would be charged with looking at what long-term funding models might guarantee that Vermonters can fully rely on EMS services into the future, what level of regional coordination and authority is needed, and how that aligns with the current configuration of EMS districts, their powers, duties, and authority. And important to note, and I think you guys have already considered this, that the study committee would be appropriate $100,000 for a consultant to support the work of the committee, knowing that digging into the data and analyzing it and making recommendations and having capacity for the study committee to really do that work, so that when they report back to us in a year, we have a really great plan about what long-term changes we can make to stabilize EMS in Vermont. And so again, appreciate you considering that request and including it in your letter to the Appropriations Committee. Lastly, to kind of get at some initial things around the workforce challenges, the bill establishes a $500 refundable income tax credit for qualified emergency service providers. So in many communities, volunteers are a critical part of our EMS provider system. And the current workforce shortage creates this sort of vicious cycle where unpaid volunteers are asked to do more, and then they burn out, and then they're gone, and then we ask the existing volunteers to do more. And so this bill seeks to provide a really modest benefit to recognize the public service of licensed EMS providers, first responders, and volunteer firefighters who are providing life-saving measures in Vermont by providing them with a $500 refundable income tax credit. So this is a big bill, but we're trying to address some systemic challenges in an important part of our healthcare delivery system. And I know you all have a lot on your plate, and appreciate you digging into this topic and having, I hope, a lot more conversation with the folks, the boots on the ground who are doing this work, and finding ways for us to do short-term and long-term things to stabilize EMS. So thanks for the opportunity to talk about this. I'd be happy to answer any questions.
Any questions for Catherine?
In here, it talks about volunteer fire. fire person. Maybe they're not going to be providing EMS services, but they're in here as getting the tax credit.
Yeah, so that's certainly like a policy choice for you all to discuss. I think the intent here was to recognize that there's emergency responders in our communities, many of whom are volunteer. This bill focuses, generally on EMS, but recognizing that our volunteer firefighters are providing sort of similar emergency response to our community that is usually in many. So this would be providing that modest benefits to recognize the public service that those volunteers do in our community. But certainly a policy decision for you all to consider about whether you narrow this to EMS and first responders and to include volunteer firefighters or not.
Alan?
Same workforce challenges there as well, is my understanding.
What was the thought process behind the $20 million appropriation for 24?
Yeah, so some of that was like modeled after the work that the Blue Ribbon Commission did in Maine. So they dug into EMS and then, made a recommendation back to the state of Maine that there's a funding gap, right? There's the full cost of the system and then there's the reimbursement rates and there's a big gap. And right now, a lot of that is falling to our towns and municipal budgets, and there are great inequities in that. I think that, wealthier communities are maybe able to provide that level of service and less wealthy communities are really struggling. I mean, I think, frankly, probably all communities are struggling to pay for that gap. And, I see that $20 million as a placeholder to say there's a gap. Let's provide a short-term infusion of resources while we do this study work to really understand the whole system and come back and propose, various paths to raise revenue and distribute those resources to ensure that all Vermonters have someone who can come to their aid when they need help.
Listen.
I didn't have a question,
Oh.
but I did want to make a comment that I wanted to thank Representative Sims because I know you've put an enormous amount of work into this and it's such an important topic, and really thanks for taking the lead on this.
Well, thanks to credit to all the folks in my community who are doing this work every day, who have talked to me about the challenges they faced, and really appreciate how hard folks are working right now in really challenging environments.
Topper and then Leslie.
Correct me if I'm wrong, right? By the way, thanks for all your work on the bill.
Okay, here comes the.
It appears to me that this is restricted to only those first responders that provide life-saving service.
So you're back on the refundable income tax credit. So when we put in statute a tax credit, we have to have intent language that's related to that. And so that is in no way to exclude. So there's clarity in the bill language about who's eligible. And Drew from Rescuing could talk to you a little bit more about the criteria that we use. But we tried to find, a clear definition of who would be eligible that covers all of the folks who are doing EMS in Vermont as volunteers right now. And the statement around providing life-saving measures is that that's what these folks are doing. It's saying you get this tax credit. The intent and the purpose of the tax credit is to recognize your public service providing EMS services, which I said here are life-saving measures. That in no way exclude the definition of who's eligible for the tax credit is in the language of the bill. And it's the licensed EMS providers, the first responders, and the volunteer firefighters.
So I just have one question, or maybe a suggestion. Should we define life-saving services?
That sounds like a great thing for you to discuss with Ledge Council and to take up as you take up this bill.
Leslie?
So yes, thank you. I hope we take up this bill. I think it is really important because I see the EMS system as the first step in the continuum of care as people, us, move through an event. It can be something life-threatening, an injury or whatever, but it also can be like what you said, just got distracted by the camera. Sorry.
It's like, wow.
It's a big lens.
It's a big lens. It's very big, wow. Anyway, the point being that the EMS system steps in a lot of different places in the continuum of care, one being life-threatening, but also they can save the system a lot of money when they can treat people at home and not have to do a transport at all or do transports to other systems. I think we have to understand the value that they give to our entire system. So that's what I'm excited about this bill, so that we can begin that conversation. Thank you.
Thank you very much.
Turn it over to the real folks.
No, you're real. Cameron, you ready? And we'll just take a minute while she gets the language up on her screen. Thanks, Catherine.
They're all outside the door.
I think Brian's coming in.
Brian always travels with a crowd.
Right. Yeah, I know. We've been out twice telling people to shush.
You want me to go out there and be a librarian?
All right. Legislative Council is going to walk us through the bill.
Good morning. For the record, Amber Navarrete, Legislative Council. I'm looking at H263 as introduced. This is an act relating to emergency medical services. The first section is a legislative findings section. Would you like me to read through this word for word, or did you?
You can skim it, but it doesn't have to be word for word, but I think it's important to put it out there. So however you want to do it.
All right. So first, the General Assembly finds that EMS is a critical part of the state's emergency response system and the healthcare system. As part of the healthcare system, EMS professionals provide critical access to healthcare services, life-saving procedures, and medical transportation to a growing number of Vermonters. The EMS system in Vermont is in critical condition. And then in 4 and 5, you have some data about the changes over the last couple of years in terms of calls answered and also turnover within the EMS industry. Moving down to page 3, EMS professional reimbursement rates do not cover the service delivery costs, resulting in cost shifting to other areas such as municipal budgets and inequities in services and coverage across the state. It is in the public interest to provide available, coordinated, and quality EMS to the individuals in the state. EMS are essential public health services necessary to link individuals to needed personal health services and to ensure the provision of healthcare when otherwise unavailable. In order to reverse the current inadequate condition of the EMS system in the state and ensure that we have an equitable, sustainable structure to support these services, changes in EMS regulations, funding, and education are required. Section 2 is an appropriations section. The first subsection A is about fiscal year 2024, and then subsection B is 2025 through 2028. So starting with fiscal year 2024, the sum of $20 million is appropriated from the general fund to the Emergency Medical Services Special Fund in fiscal year 24 for the purpose of deferring the costs of unreimbursed emergency medical services transport and non-transporting emergency medical services, training and continuing education costs for emergency medical services providers, the purchase of medical equipment to equip ambulances, and emergency medical services district administration costs. Subsection B is for fiscal years 25 through 28. 1, it is the intent of the General Assembly that a sum of not more than $20 million is appropriated from the general fund to the Emergency Medical Services Special Fund annually for fiscal years 25 through 28 for the purposes described in subsection A of this section. And 2, it is the intent of the General Assembly that delivery of emergency medical services is annually funded with $20 million for those fiscal years by an appropriation from the general fund to the Emergency Medical Services Fund. However, the appropriation amount should be reduced to the maximum extent possible through the utilization of public and private Medicaid match programs. 3, the purpose of state funding under this section is to improve access to emergency medical services while the state works towards establishing a long-term statewide system of funding to provide this essential public service to all Vermonters. Section 3, emergency medical services. This is adding a new section into Title 8 on insurance. So first, in subsection A, we have definitions. First, emergency medical services providers and EMS providers mean emergency first responders, emergency services responders, emergency medical technicians, advanced emergency medical technicians, and paramedics. Health insurance plan means any individual or group health insurance policy, any hospital or medical service corporation or health maintenance organization subscriber contract, or any other health benefit plan offered, issued, or renewed for any person in this state by a health insurer. The term does not include benefit plans providing coverage for specific diseases or other limited benefit coverage. Health insurer has the same meaning as in Title 18, Section 9402. Subsection B, required coverage. A health insurance plan shall cover all reasonably necessary costs associated with the emergency medical services provided by an EMS provider to a patient who is not transported, subject to all co-payments, co-insurance, or deductibles. So that is for commercial insurance. The next section is regarding Medicaid coverage. This would add a new Section 1901L to Title 33. Medicaid coverage for emergency medical services. First, in subsection A, you have definitions. Ambulance service has the same meaning as in Title 24, Section 2651. Emergency medical services provider has the same meaning as in the section that we just created in Title 8. Subsection B, services without transportation. Vermont Medicaid shall provide coverage of emergency medical services provided by an emergency medical services provider to a Medicaid beneficiary who is not transported to a different location during the period of emergency, as defined by the Agency of Human Services by rule. Subsection C, transportation to alternative destination. Vermont Medicaid shall provide coverage of transportation services for a Medicaid beneficiary to an alternative destination when the beneficiary's condition does not meet the definition of emergency medical condition as defined by the Agency of Human Services by rule. Vermont Medicaid shall not provide coverage of transportation to an alternative destination unless the Medicaid beneficiary consents to being transported to that destination. And no ambulance service shall transport a person to an alternative destination in which the ambulance service has a financial interest. The Agency of Human Services shall establish by rule a reimbursement methodology to cover alternative destination transport by a ground ambulance service provider to ensure that reimbursement rates are reasonable and adequate. Section 5 is directing the Agency of Human Services to request approval from CMS, the Centers for Medicare and Medicaid Services, to amend Vermont's Medicaid state plan to include the coverage that we just covered in Section 4. Section 6, regarding Medicaid and transportation about provider reimbursements. It is the intent of the General Assembly that Vermont's healthcare system should reimburse all Medicaid participating emergency services providers at rates that are equal to 100% of the Medicare rates for the services provided. In support of this goal, in its 2024 budget proposal, the Department of Vermont Health Access shall either provide reimbursement rates for Medicaid participating EMS providers for emergency medical services at rates that are equal to 100% of the Medicare rates for the services in effect in calendar year 2022, with positive medical inflation adjustment rates in subsequent years, or in accordance with 32 VSA Section 307D6, provide information on the additional amounts that would be necessary to achieve full reimbursement parity for medical services with the Medicare rates. Excuse me. The next section, 7, is the EMS study committee. Shall I just?
So, right, so if everyone remembers, we actually put this in the budget language. So I think for now we can skip this part. Melanie will bring you up to speed.
So I am scrolling all the way down to page 11. And here's the income tax credit. Just as a slight disclaimer, my colleague, Abby Shepard, in the Office of Legislative Counsel drafted this because it is a tax and I do not know much about taxes. So I will read you the language on the page, but for questions, I will need to circle back to her. So section 8 adds section 50 5830G to Title 32, tax credit for emergency responders. Subsection A, a qualified emergency responder shall be eligible for a refundable credit against the tax imposed under Section 5822 of this title during the taxable year in the amount of $500. As used in this section, qualified emergency responder means 1, emergency medical personnel as defined in Title 24, Section 26516, and first responders as defined in Title 24, Section 2651110, who are licensed by the Department of Health pursuant to Title 24, Section 2681. And 2, volunteer firefighters, provided the firefighter is an active member of a local volunteer firefighting company as certified by that company. Section 9 is the intent language for this tax credit. We would add Section 5813AA into Title 32. The statutory purpose of the tax credit for emergency responders under Section 5830G of this title is to recognize the public service of licensed emergency medical personnel, first responders, and volunteer firefighters who, and this should either say provide or are providing, life-saving measures in Vermont. As for the effective dates section, Section 3, which is our commercial health insurance coverage, shall take effect on July 1st, 2024, and apply to all plans that are issued within calendar year 2024. Section 4, which is Medicaid coverage, shall take effect upon approval by CMS's approval of Vermont's request to provide coverage. Section 7, the study committee, take effect on July 1st of 2023. And then the income tax credit shall take effect retroactively on January 1st, 2023, and shall apply to taxable years beginning on and after January 1st, 2023. And the remaining sections of this act would take effect on passage.
Thank you. Questions? Catherine?
I have that same question. We're saying that qualified emergency responder, and we define it. But then later on, we say volunteer firefighters, provided the firefighter provides life-saving service. I'm not against this thing. I just want to make sure we get it right.
I can check with Abby Shepherd, who drafted this language, but reading here, the Section 8 is where you are providing the parameters for the tax credit.
Mm-hmm.
So you have emergency personnel as they are defined in statute, first responders as they are defined in statute, and volunteer firefighters, provided the firefighter is an active member of a local volunteer firefighting company as certified by that company. So there is no qualifier here in terms of whether the firefighter provides life-saving services. Section 9 has the intent language, which says the purpose of providing this tax credit is because these categories of people provide life-saving services. So I can check with my colleague, but I would not read the purpose language as providing any restriction on the credit being provided.
Okay, I
can check.
You can check it and
I will.
make sure.
I will.
Because the way I read it, is we were limiting it to those first responders that provide life-saving services. So I'll leave it at that, and you can, thank you very much.
Are,
I have a question for you, Lori. Are we trying to advance this year?
we are going to take testimony today, and then we are going to see where the committee is on moving it forward. And so then we would hear a lot more testimony. I will say some of the timelines don't work here anymore because the budget is out of our hands of this committee. So dates would probably have to change. And then the other really important date that would have to change if we do anything with commercial insurance, Shores or Medicaid. Remember, for those of you new to the committee, like their plans, rates for next year, I think, Mike, can you help me? Are initially due for the insurance companies, like everything gets approved soon. So, I mean, they have to be submitted by the end of March, I think, around that time. Some of those dates will have to change as well. Mike's shaking his head, yes.
Can we do something in the budget adjustment?
So, and then just to remind everyone, what we did in the
So,
budget was we requested an increase to 100% of Medicaid for their reimbursement rates. We requested $1 million for training, and we requested $100,000 to go with the study that's already in here. Right now, all of that is still on the table in appropriations. Budget will be voted out probably the end of this week, early next week. And so we'll know where all that stands to determine again how this bill could be impacted if we move it forward.
but the focus right now is on the language.
The focus right now is on the language in the bill and what we hear from people on the streets and, you know, those doing the work, insurance companies, Medicaid.
Okay.
So
I know just from me, I'd like to see maybe a more specific definition of an EMS individual, just so I know who the money goes to.
Okay, great. Any other questions for Amber? Thank you very much. We're going to switcheroo our seats here, so you can stay if you'd like. And then next, we are going to have Drew Hazelton join us. Come on up. He's the chair of the Vermont EMS Advisory Committee. He's been in here before. We have a new member, Melanie, so otherwise we will not do introductions. So welcome.
Thanks for having me back. And I greatly appreciate the committee taking the time to look at this bill, and certainly the work that was done by Representative Sims and the other sponsors early on, and the engagement that they've already had with the stakeholders, including the EMS Advisory Council, the Ambulance Association, and others, including the league.
Drew, can you just introduce yourself?
Oh, I'm sorry, Drew Hazelton. So I am the Chief of Operations at Rescue Inc., but today I sit representing the EMS Advisory Committee, which is the stakeholder group that writes the EMS report every year that you should have here. And you'll see themes in the bill that you're looking at that very much match the challenges that were identified through our EMS Advisory Council. So we're very much in support of the language and legislation that's been proposed. What I'd like to do is just give you a little bit of a background to bring everybody up to speed on our EMS system and where it's at. So EMS in Vermont, like many parts of the country, started in the 60s. And it was started through a need to respond to traumatic injuries and transportation to hospitals. And that's how our system here popped up. And a lot of small communities just kind of created their own organic systems. Those systems in many places are still operating today. In Vermont, many of our systems are still volunteer or partially volunteer, providing EMS in a very different way than it was originally envisioned. EMS of the 1960s, 1970s, early 1980s was really first aid and transportation. EMS of 2023 is healthcare. What you're expecting, what you're receiving in the back of an ambulance, our modern EMS system is pretty remarkable. You're seeing advanced cardiac life support. You're seeing ultrasound. You're seeing the ability to do medical procedures that were typically limited to ICUs, hospitals, and other areas. And what we have for a system today that is very different is still being funded the way it was in 1970. And this is our challenge. EMS is considered a transportation service in the world of healthcare. Yet what we provide now is far more than transportation. For example, medications used in ambulances can't be billed for. So the new, as I'm sure you've heard, medications on the market come at a very high cost. But they are the best treatments and they provide the best chances of survival for our patients. We carry those, we administer those in the field in people's homes, but we can't get reimbursed for any of that. We're reimbursed as a transportation benefit by the mile, much like Uber. So what we're excited about, many things in this bill are exciting. One of them is kind of looking at the funding structure, looking at the study that we're talking about at the end of the legislation modernizing the way Vermont looks at our EMS system. Let's bring it up to date with the services that we're actually delivering. And EMS is delivering modern healthcare. But EMS in Vermont is struggling because of the same reasons healthcare across Vermont and across the country is struggling. And that's personnel. So we've done what we can. So our EMS system has rallied over the last 3 years through COVID, through the workforce challenges to create new programs. We've created training opportunities. We've created workforce development. Certainly appreciate the support we've gotten from the legislature with one-time funds over the last 5 years. Each year we've asked for funds. We've received some money towards providing education. And we've been very successful at that. But we're still losing more EMS providers every year than we are able to bring into our system. We're still not able to keep the education and certification levels at a point where we can reliably, system-wide, support the needs of Vermonters in every corner. In many communities, without the workforce bill, which we greatly appreciate you guys supporting, in many communities, for the right to be a volunteer, you must first come up with $1,500, spend 6 months in class, just for the right to be a volunteer. Without the money that is currently in the workforce bill that we're hoping stays, the total state investment for EMS education is $150,000. When we're trying to replace 25% of our workforce every single year, that money doesn't go very far. The communities that we serve don't have the financial resources to support those costs. Many of these departments are fundraising their dollars in order to help keep property taxes low. They're fundraising dollars to buy medications, to replace ambulances, to replace stretchers. A simple stretcher setup in an ambulance now is over $50,000. These costs are being pushed out onto the volunteers to find and fund. That's why our system is struggling. So we have a personnel crisis that's being complicated by a antiquated reimbursement system. And certainly moving the bar of Medicaid reimbursements from where it is to 100% of Medicare is a step in the right direction. It's not going to fix the kind of the fundamental challenges that we face, but it's a step in the right direction. Making $1 million investment in EMS education this year and hopefully every year will help us to provide the initial education along with ongoing education. EMS providers are required to do required to recertify every 2 years. We actually have more robust recertification and training requirements than the rest of healthcare. As a critical care paramedic, I'm required to do 100 hours of continuing education, where, for example, nurses their requirements are very different. That education is extremely expensive and difficult to come by in Vermont. So we need these funds in order to bring these programs to Vermont so that we can actually keep our staff trained and educated. The treat no transport that you heard a little bit about is complicated. So in many areas, in many cases, we can provide the services a patient needs in their home, and we can avoid the transportation to the hospital. In a lot of our calls, in some areas upwards of 20%, those patients do not need to be transported to an emergency department for their emergency. It may be that they can receive, for example, diabetic treatment at home. They can receive Narcan in the field. We can get them to a point where they don't need immediate care. It may be that we can stabilize their ankle injury or arm injury and they can follow up with their physician. And most people in those scenarios prefer not to go to the emergency room. And as you heard, we don't get reimbursed for those services in most cases. So we need a way to recover on that 20% of the call volume that we go out on, because again, we can't bill for those services. We can't bill for those supplies. We can't bill for that time. So again, EMS has tried to help itself. Our advisory committee has worked with our EMS office. We've created a new Vermont responder level in Vermont, became active in February of last year. That allowed us to draw some additional personnel into EMS. It's helped to get some interest back in kind of becoming a first responder in Vermont. It's a entry-level class. It's 20 hours, lets people kind of get a taste of what EMS is like. It's been very successful with over 400 new first responders in Vermont. But we now need to be able to support those people and bring them through the rest of the EMS training. I think that's really kind of the high-level overview. If there are any detailed questions, I have copies of the legislative report if anybody hasn't had a chance to read it. I'm sure it's in your mailbox.
Yeah, it's also in it's on our website.
If anybody wants one printed in color, I brought a couple. You want one? I didn't bring enough for everyone. Well, I brought enough for everybody. So, yeah. And again, the themes here are very similar.
Great. Couple questions. Art first and then Alan.
Yeah, I mean, maybe this answers my question. I'll get through, but what I wanted to kind of, and I know nothing about what you do, and I know nothing about this system, very little. I had, unfortunately, have ridden it once you provided, but I'd like to know how you are funded. What is the funding structure now? And is there a way to, you mentioned you don't get reimbursed for prescribing drugs. You don't get reimbursed for this, that, and the other. Maybe there's an opportunity there to change that and thereby change the structure of your payments. I would just like to see from someone how you are paid, how the money flows so that we can make a informed decision on it.
Yeah, so I can give you a little bit of insight. So EMS in Vermont is delivered in many different ways. So we have straight municipal models where a municipality has an EMS department. In that case, they're funded through the property taxes as well as whatever they can receive on from reimbursement. We have models that are in quantity, a lot of our volunteer services, they're volunteer nonprofit, and they fundraise the losses, and they receive money from Medicaid, Medicare, and private insurance to kind of balance their budget. We have
You're saying there's a mismatch.
Oh, in Vermont, very, very much a mismatch.
Okay. I mean, you don't have to go into the details here.
Yeah, so I'll talk about our system. So just because I know that one really well, we're a regional nonprofit. So in order for us to operate, we receive money from Medicaid and Medicare and private insurance. We do fundraising and grant, and about 17% of our budget is back onto the property taxes because we're not able to support our operation simply with what we can get. The unfortunate part of that is those property tax payments we're using to subsidize the Medicaid system. And unfortunately, we're not seeing the federal match on those.
Okay, yeah. All right, well, I mean, that's, it would be interesting to see how you would take the 20 million and use it.
And just to give you one more example in our community, so we have a nonprofit EMS system that serves 5 towns. And they came to every town this year for a substantial increase in their municipal property tax funding, and all the communities gave it. It was hard for all communities, but obviously 911 is, it's the most fundamental thing we can provide, so that it's an issue everywhere. So we have Alan and then Mari.
Just curious, when you don't get paid for non-transporting patients, do you have a percentage or data on the difference between transport and not transporting?
So it's about 20%. Some areas of the state are higher, and it does change with our services are so small, it changes by the specific patients. So you can have a high utilizer in an area that will drive your non-transport up. So for example, we have a rural office in our location in West Townsend, Vermont. We had one patient that called 911 330 times in 12 months. So rarely going to the hospital. So we have a very high non-transport rate. But an average across the state, you could use 20% is kind of a baseline of patients that don't receive transport. One thing I didn't mention is, and I think the point was made earlier, but I just want to emphasize, not only is EMS the access point to our healthcare system, but we're also the connecting piece between our rural community hospitals and life-saving services at trauma centers. That's quite often forgotten. I mean, I even forgot it myself in the beginning of this conversation. But we could relocate your healthcare emergency to a local community hospital that doesn't have the tools or the resources to take care of your cardiac condition or your trauma. And though that's a service, that's not a service we need. So we also need to make sure we're supporting that piece, which is the hospital transportation necessary to get people to definitive care. And I'll say that part of our system is struggling almost more so than the 911 service.
So can we just expand on that a little bit so I understand it? So you're saying if you're called to one of your rural communities, and you know that person has to go to a hospital, but they need to go to a hospital that's not in your community for their level of care, do you take them to that hospital outside, or is that what you're saying?
So sometimes, so it depends on how close you are. So, Vermont geography plays a big part in all of our decision making. So if you say live in an area near White River, then your primary hospital is Dartmouth-Hitchcock. So you're going to go to a hospital, they have all the services that are available. If you're in the Chittenden County area, then you're going to have that luxury. If you are where I live in Rawsonville, down by Stratton, it's an hour to a hospital, any direction. But it's also 2 hours to a trauma center in any direction. So in those cases, the local ambulance service will transport to a community hospital. The community hospital will help to provide stabilizing treatment for their cardiac or the trauma, but then they need to continue. And it falls back to EMS to get them to the cardiac cath lab or to the trauma center. And we quite often forget that piece. But without that, we cripple our hospitals. Right now, one of the challenges that we're seeing across the state is that ambulance services are struggling to the point where in order to provide 911 coverage, they're not able to provide the hospital transportation. Because given the choice, they're committed to providing 911 service, so they're not able to provide timely service to our hospitals. And now we have patients, not only our mental health population that are getting stuck in hospitals, but we actually have patients that need life-saving surgeries that are getting stuck at hospitals around Vermont because the EMS system can't keep up with the volume of movement.
Thank you for clarifying that. We have someone on the screen, just so you know, she's going to be talking behind you. Mari.
Hi, Drew. Good to see you. Thanks for coming in. Can you repeat the amount of continuing education hours required?
So it depends on, look up here, right? Where do I look? The camera.
It's weird, I know.
So it depends on the license level. So in Vermont, we have a Vermont responder, we have a first responder, we have an EMT, an advanced EMT, a paramedic, and a critical care paramedic. And as you work and progress through those different levels, the number of hours to recertify increases. So a Vermont responder will need to do about 20 hours every 2 years. An EMT does 72 hours. And then as you move to the critical care paramedic, we do 100 hours as part of our training and education. On top of that, continuing education, we also have to maintain advanced cardiac life support, pre-hospital trauma life support, pediatric emergency. So and those are all standalone programs that we're also required by Vermont rule to maintain as EMS providers. So there's a lot of education that is required.
And then you have to use the certification programs like ACLS. You have to train the trainers, which is another cost, or use a program that trains trainers. So I want to validate what Drew is saying about continuing education and nurses. Nurses have no continuing education requirement in Vermont. We do have to work a certain number of hours per 2 years or per 5 years. But that's a lot for especially I think EMTs, depending on where you are and whether you're a volunteer, especially if you're a volunteer and you don't have access to funding, that's a lot.
Drew, is that a state requirement? Is that a board, whoever,
The national requirement.
a national requirement? Interesting.
Yeah, so Vermont's a national registry state, so those standards are set nationally. One of the things that we have been able to do in the last, well, we did it last year, I don't think we did it the year before, is we were able to get some state funding out of the special fund to help pay for the continuing education programs. Because not only do we ask our volunteers to pay for their initial education, we also ask them to pay for their continuing education. So in the last year, we were able to find some money to provide some of that training and education at no cost. In that $1 million that we asked for, it does include continuing.
It does, that's what I was
money, so that we can help to offset the cost of maintaining that ACLS and PHTLS and PALS, and you can call them alphabet soup classes because they all
Sounds like it.
that we all have to maintain.
Okay, so we have Alyssa and then Bobby and then Leslie, and then we are going to have to move on because we have 2 more witnesses.
So I'm wondering if, because you're not reimbursed unless you transport, if you found, is there any pressure to transport when it's not really in order to get reimbursement? And on the flip side, because I know we've talked to our local EMS, I know that they've expressed concerns because they're called out to, particularly we have a lot of skilled nursing facilities in our community, and they're pressured to transport when really they don't think they should. And I'm wondering if you could speak to that.
Yeah, so, and there's no easy answer to that. So the challenges around treatment and I guess we'll call it treating and leaving at home, or treating it and however we want to call it, treat without transportation, in some ways right now is challenging because we don't have the ability to necessarily get them to the appropriate service. So they may not need to go to a hospital. They may not want to go to a hospital, but they need care. As an EMS provider, our only option right now is an emergency room. So we will pressure patients to seek care in the only way that we can get them care. So right now it's like you may need urgent care level, not ER level, but I can't recommend urgent care by ambulance because we can't do that. Does that make sense? The same thing happens when we go to skilled nursing facilities where they probably don't need to go to an emergency room to receive the treatment. They should probably be able to get, say, for example, IV rehydration therapy at a nursing home. But in the absence of a better option, the emergency room is the only place we can go. And I know if the hospitals were standing here, they would say, please don't.
Right.
But unfortunately, that is our only option. So we direct people to the ER because that's where we have to take them.
Yeah, we talk about like mobile crisis units in this committee for mental health, and you all are like the original mobile crisis unit, but you're really hamstrung on what your options are.
I could go on for days about our failing mental health response and why we do everything I shouldn't say everything, most everything we do in EMS does not help.
Right.
Take our mental health patients to one of the most stimulating environments that can't provide services to them. And I feel terrible, but unfortunately, that's the only option we have.
Quick follow-up to Alyssa's question. So on the not being able to pay for a transport to urgent care or treat at home, is that a Medicaid regulation? Do insurance companies, commercial insurance companies reimburse you for either of those?
So it starts with Medicare.
Starts with Medicare, right?
So unfortunately, the Medicare is our biggest problem, and they're also our biggest payer in Vermont. So Medicaid has a code for treat no transport. I've been actually in conversation with them trying to come up with clarity as to what the definition of treat no transport is and kind of how that code may be utilized because of this legislation. There are some instances where our private insurance companies will pay. So COVID actually opened up some doors and some opportunities early in the pandemic when the hospitals didn't want anybody being transported.
Right.
And Medicare at the time, which made Medicaid available, and the private insurance companies accepted that we could treat patients in their homes and choose not to bring them to the hospital if they met certain criteria. So it's more common now than it was pre-pandemic, but it's still not. And I know Medicare just recently removed that allowance post-pandemic, so we're back to where we were on the federal level, back to not being able to do that.
Okay. This is a quick follow-up, and then we really are.
Could you remind me, because last time you were in here, we were talking about dual eligibles, and there was one particular service, I think, that I remember that you were not able to bill Medicaid for because it's denied by Medicare as not covered. And which service is that?
Treat no transport.
Treat no transport. And Vermont Medicaid has not made an exception to pay a secondary, even though it's a non-covered benefit by Medicare?
Correct. I've asked them to, and they're going to get back to us, and I'm sure they'll get back to, I think they'll get back to you quicker.
Thank you.
Then we will have them, where we talk to Diva. Bobby?
Well, I was shocked to hear that you don't get reimbursed or you can't bill for medications and supplies that you use during a call. What's the origin of the history of that rule, and how can we change that?
So, unfortunately, that starts at the federal level. So EMS on the federal level still actually lives in the Department of Transportation, because it started as a response to highway crashes. So in the kind of the realm of EMS, this concept of there's a base rate and a mileage, but we don't get to bill for individual procedures or medications, starts at the federal level. There is an allowance for Medicaid to bill for oxygen, which is a little bit unique in Vermont. It doesn't happen in all states, but there's nothing to bill for. So, for example, amiodarone, when it came out, was $300 a dose. So a cardiac patient receiving $300 a dose medication, a $221 reimbursement doesn't really work out well for the service providers.
I'm just going to make a comment that hopefully someone will remember to talk to if we get H414, which is the used drug repository bill out, that potentially there's a tie-in to EMS, right? To be able to redistribute to, hopefully we fix the problem better than this, but if there's the ability to redistribute medications, that might be helpful. Leslie?
So I'm very concerned about the issue of equity. When we look across the state and there's this hodgepodge of a system, depending on where you live may determine whether you survive. And I think that's a crucial part of our problem in dealing with our EMS system statewide. So that's one of the reasons I think this bill is so important. And I was wondering if you had any comments, and I haven't had a chance to read this yet, about equity and how you think we should think about it.
So our system is not equitable. So your assessment is correct. And unfortunately, because of the towns that have hospitals are also the towns that typically have resources to support EMS through local property taxes. So what happens in most communities, it's not an absolute statement, in most communities, those hospitals that are central around the population center of the hospital have the highest level of EMS care. And quite honestly, they're the areas that need that the least because they're closest to a doctor and a hospital. Where our rural communities, the ones where, for example, where I live in Rawsonville that are an hour to the nearest hospital, we really need the highest level of care provided to those systems. And from an equity perspective, those are the areas that are currently most underserved. Because again, there's not enough resources to hire on and have paramedic level service in those areas. There are services that do provide volunteer level paramedic care in Vermont. I don't know how those volunteers can find the time and commitment to spend what in Vermont can be up to $50,000 on paramedic education and the continuing education. And I certainly applaud them. But those services are becoming fewer and fewer because the requirements are getting harder and harder. And as we're kind of watching the system fall apart, which it is, I know that in our area, we're responding further and further out to our neighboring communities to provide them support. We were 4 towns away. I mean, we had to drive through 4 separate towns to provide paramedic level service to a patient that couldn't get it. It's not getting better.
So if I may, is that where the $20 million supports what these rural, I mean, that's why I'm thinking about equity and the money going. So I just wanted to understand that. But I know we need to move on.
We need to move on. Okay, thank you. Thank you, Drew, and I'm sure we'll be seeing you more, so.
Thank you, Drew.
So we're going to turn to Will Moran, who's on the screen. Thank you, Will, for joining us. He's the EMS chief for the Vermont Department of Health. So welcome.
Madam Chair, thank you very much. And members of the committee, it is my pleasure to speak with all of you today. So for the record, my name is Will Moran. I serve as the director of the Division of Emergency Preparedness, Response, and Injury Prevention. This also includes the Offices of Emergency Medical Services at the Department of Health. So I recognize we are short in time, so I'm going to keep this pretty clear and concise. What I want to say to you today is that, when a Vermonter has been injured or is experiencing a medical emergency, it's vitally important that they have dependable and rapid access to pre-hospital emergency medical care and timely specialized ambulance transport to an emergency department. To do so requires, a complex support system of regulations, education and training, licensing, medical direction, local resource readiness, and systems of quality assurance and quality improvement. The cost of readiness is high, and I think we for the last half an hour have heard from Chief Hazelton about that. And what I would also say is the public's expectation of the emergency medical services system is even higher. My team and I in the Office of Emergency Medical Services, we pride ourselves on having a level of engagement and collaboration and communication with representatives from across the emergency medical services community within the state of Vermont. We are present and active participants in meetings with the EMS Advisory Committee, the EMS Education Council, the Vermont Ambulance Association, the Vermont Career Fire Chiefs, the Vermont Association of Hospitals, and others. We do our best to stay informed, to be a partner to those folks across the state who are out there delivering these vital services. We also take into consideration those Vermonters who rely upon the emergency medical services system to meet their emergent and non-emergent healthcare needs. As for many folks, especially in rural areas of the state, oftentimes they rely upon the emergency medical services system as their means of primary healthcare. So every year, the team and I push out across the state and host regional meetings. So we hear directly from EMS district executives, physician medical advisors, EMS service chiefs. We foster relationships with the EMTs, advanced EMTs, paramedics, and others. Those folks that are out there answering the public's call for help day in and day out. I can assure you the Department of Health leadership and I are aware of the ongoing challenges faced by the emergency medical service system here in Vermont, and the opportunities that we also see that exist in the future. So my message for the committee today is that we are sympathetic. We are sympathetic to the challenges that exist today, and also remain committed to being an active participant in seeking out solutions that lead to system stability, system resiliency, and ultimately long-term viability. The Department of Health has been and will continue to be a champion for a modern emergency medical service system that delivers high quality, efficient, and effective evidence-based care. So I thank you for the opportunity to speak with all of you today. And with that, I yield back and I'm happy to answer any questions you might have.
Great, thank you. We have Topper, Brian, and then Leslie.
Thanks for coming in today. Could you explain to the committee, please, what sympathetic means?
Yeah, for sure. So, as I outlined in my testimony, we participate in every group, every stakeholder group that is an active member of the emergency medical services system in one way, shape, or form or another, whether it's hospitals, whether it's our fire-based partners, whether it is Vermont Ambulance Association or others. We hear the challenges folks are talking about, and we actively engage in collaborative solutions to overcome those challenges. So for example, Chief Hazelton talked about the extensive success we have had in training new emergency medicine or new EMS practitioners, but also supporting those folks that are already in the system. And we've done so through offering at no cost education to folks, right? So if if you are someone looking to become an EMT and you're staring at a price tag of $1,500 to take that class, since June of last year, you've been able to take that class at no cost. And what we've seen is that when you remove the barrier of cost, folks actively engage and take advantage of the opportunities that we can offer them. So when I use the word sympathetic, what I'm trying to convey is that we are actively engaged in the process. We're actively engaged in problem solving, and we look to utilize every tool at our disposal to remove the barriers that prevent our EMS system from flourishing.
So can I interpret that to mean that you support this bill?
Yes, Representative, that's a great question. Unfortunately, I'm not in the position to answer that question today, and I would defer you to the Commissioner's office for an answer.
Okay, thank you. I have a follow-up question. You said since January you've been offering those classes for free, but without the $1 million we put in the budget, would that offering go away? Are we close to running out of money?
Yeah, so the answer to that question is no. So we started offering free education courses on June 1st of 2020. Yeah, June 1st of 2022. We utilized $572,000 of unallocated funding in the EMS Special Fund. So the EMS Special Fund has been in place since 2012. Since that time, those funds have been targeted to EMS districts. Those EMS districts that have chosen to take advantage of those dollars, some have, and many EMS districts have not taken the steps to receive those dollars. So what has happened is over the last 11 years, that fund built a surplus, and we put forth a plan last year, about a year ago, to utilize those dollars to offer free education across the state. So between June 1st and the end of November, we spent more than $300,000 to offer a range of educational opportunities, everything from free licensure courses, folks who want to become an EMR, an EMT, or an advanced EMT. We offered a range of continuing education and refresher courses. So when Chief Hazelton mentioned the continuing education requirements that folks are required to complete every 2 years, we made all of those credits accessible to every person in our EMS system at no cost to support their continuing education endeavors. We provided several courses to increase the number of critical care paramedics we have across the state. And then we also funded a range of other activities to support, or other educational opportunities to support our EMS educators, to provide leadership training for our current EMS leaders and our up-and-coming EMS leaders. And we've also branched into continuing education opportunities for our critical care paramedics. So we have left no stone unturned when it comes to meeting the needs of the approximately 2,900 people that are part of our EMS system.
Okay, so I just want to clarify. So you did all that, which is amazing, but there's no more money left.
Well, no. So we're still sitting on a little more than $200,000. Okay. And we presented to the EMS Advisory Committee last month our plan to start offering the next round of free EMS education opportunities. And we will continue to do that until we exhaust that fund.
Okay. And then I have a follow-up. So did we learn anything through this process since June? I was concerned about what you said, that the fund has been in place since 2012, but not all towns were taking advantage of it. So have we learned through this process that there could be better, more efficient ways to get this money out to the towns without them having to do the work to get it?
Yes. So and just to be clear, it's not the towns that take advantage of it. It's our EMS districts.
I'm sorry. That's what I meant to say.
Yeah,
yes.
that's
right.
No problem.
Yes.
So what we've learned, so that's actually a really great question. And what we have learned is that the EMS Special Fund, when essentially the State Emergency Medical Services Office takes on the burden of coordinating the offering of free education, we remove the barrier of EMS districts having to own the responsibility to reach out and meet our granting requirements to be able to pull that money down. So when we take ownership of those dollars, and we fund education, and we ensure that there is equitable access across the state, what we see is that the EMS users themselves, the consumers of the education system, take every advantage they can to access those educational opportunities. And, we are proud of the work we've done. And I think Chief Hazelton would, and certainly did allude to, the success that we've had in providing free and at no cost initial education courses and continuing education opportunities.
Okay, thank you. So Topper, and then I'm going the original rotation of Ryan, Leslie, and then Mari.
All those things that you've talked about are wonderful. I'm just wondering, because I can't remember, is there money in the budget to continue this, what you've been doing?
So in a very limited way. So we are, as I just mentioned a few minutes ago, we are still working to spend out the surplus.
Yeah.
And then historically, the annual allocation from the legislature has been $150,000. What we have determined after reviewing 2 years of educational data was that we know the cost of education on an annual basis is, or I would say it this way, the EMS system spends, and I'm talking about the users, or the folks that are the EMS practitioners out there, they spend more than $1 million pursuing education opportunities, whether it's, taking licensure courses or pursuing continuing education courses. So we know for 2 consecutive years, they spent more than $1 million every year pursuing those opportunities. And historically, the annual allocation from the legislature, just to be specific and answer your question, is $150,000.
Yeah, so, and forgive me to any of the witnesses if something was mentioned and I didn't register it, because sometimes a lot of information to process. One thing, I've been looking at the bill while listening to you and just thinking that comes to mind is that the way this bill is currently written, there's like a study that talks about coordination of services, and it's very siloed. And this is not a critique, it's just an observation. Like it talks about decreasing costs, improving EMS coordination, increasing access to emergency services within a district, and optimizing the structure. But it doesn't talk more about coordination between EMS and other components of the healthcare system. And like I heard one of the witnesses mention, like that the mental health system is failing or something like that. I think the whole healthcare system is failing. And like as a mental health emergency responder myself, what I see happen is if you have skilled individual workers in a crisis or a situation, we figure it out. Like we're just like, we'll talk, you'll see in like the different teams, 2 people will click and it'll work out. But there isn't a lot of cross training that I've seen and a lot of like coordination between the different components. So I just wonder if there might be a place in that study to look at coordination between EMS and other kinds of, other pieces of the healthcare system. And I'm not saying it isn't happening. I wanted to ask the question and see if there was space where people might reflect on that. And then I'll ask my other question, and then you can kind of choose how you want to approach it. The other question is, and this is where I might have missed something, is the bill is very focused on Medicaid and Medicare, no, just Medicaid, because we can't really do Medicare. And I guess I'm just curious, like, what is the deal with private insurance or uninsured people? And how does that play into this? Because, I don't know if I missed something. But
There's a piece in this about commercial insurance.
Okay.
Yeah. But keep going, because it is.
Yeah, well, I guess what I'm getting at is like, it sounds like Medicaid's not paying enough. So, how is private insurance doing? And like, in general, it seems like we built this healthcare system that we can't sustain. And so like, what are we going to do? I mean, I don't know. Yeah. But I'd like to make space now to just hear from people, like your response to those concerns and questions.
Yeah, thank you. So great question. So to answer your first question, what we're seeing across the country is, and the model that's typically used is referred to as community-based paramedicine, right? So our paramedics are our most highly trained EMS practitioners. And what we've seen have great success in other states both rural and urban and in suburban environments, are the creation of what is referred to as community paramedic programs. And sometimes these programs are very targeted, where they are, you are seeing a team, right, of, maybe it's a paramedic, maybe it's a, it's a paramedic, it's a mental health worker and a nurse going out and trying to engage those folks that perhaps are high system users to begin to address the problems that they experience on a daily basis, and for which they have historically relied upon the emergency medical services system and the hospital system to solve their problems, because there is a gap between where they are at and what they need. And so we've seen this happen in a range of activities around community paramedic programs, everything from post-surgical follow-up to in 911 systems, identifying those patients that are good candidates for treatment in the home, and it helps avoid the unnecessary admission to an emergency department. Now, that type of system, that type of coordination and all the pieces and parts that are required to make it work requires funding, requires coordination, and a whole layer of those things that we don't currently have in our state. Now, that being said, the Office of EMS stands ready to support those teams that want to pursue that. We do see that as an emerging opportunity. To answer your second question, and I'll focus on it this way. So one of the things that's unique about reimbursement for services rendered in the EMS system is, and I'm going to use an analogy. If I called a plumber to fix a leak in my house, I don't get the opportunity to negotiate the bill after the fact, right? The plumber sends me the bill and they expect me to pay whatever it is that they billed me for. That's not the case for EMS. An EMS service will go out and they will unconditionally deploy all the necessary staff, the very expensive equipment, and utilize all the consumable supplies and medications they need to ensure that patient receives high quality care and they are linked to an emergency department and therefore the next phase in the healthcare system. That, after the fact, there's a bill submitted to the commercial insurance carrier. And what happens to EMS is there's no assumption you're going to be paid for what you billed them for. They will respond back to you and say, you billed us $1,000, we're willing to pay you $560. And there's really very little opportunity to negotiate that. It's essentially take it or leave it. So that does put EMS in a very difficult position when, our EMS services do not pre-qualify these patients. There's no opportunity to review the case ahead of time. When the bell rings, they go, and they will utilize every means at their disposal to ensure that person receives the right timely care, to ensure that they have the best possibility for a positive health outcome. And we do so without taking into account what the cost might be and or what we might get reimbursed. We deal with that after the fact. So that is one of the struggles that EMS has historically been faced with, is that regardless of what we bill for services rendered, there's no guarantee that we'll be paid the actual cost of delivering services. And that is a challenge.
Thanks. That's the same problem I think that we see across the entire healthcare system.
Sure.
So I'm glad we're looking at it here, but I mean, it's too bad we can't just fix it for everyone at once.
Okay.
So.
Leslie? Thank you, Will, very much. I'm looking at the website, the VDH website for emergency medical services, and it says EMS is an integrated system for emergency medical treatment and transportation of sick and injured patients. And I'm wondering what VDH means by integrated system.
Yeah, that's a great question. So EMS is not, it is not one thing, right? So it is a system of EMS services. It is a system of EMS practitioners. It is a system of physician medical directors. It is a system of educators, right? When we talk about systems, we talk about all the necessary components that are necessary, starting with state statutes and ultimately what is the EMS rule that provides the framework to operate an EMS system. So when we talk about systems, we talk about all the necessary components from start to finish that allow an EMS service to function. And we've touched upon several of those things so far today. Does that adequately answer your question?
Yeah, I think I understand, if I may. So do you feel like it's adequately integrated at this point? And given what we've heard and we heard about, it seems a little chaotic. So I'm just contrasting those two ideas.
Yeah, I think that's a great question. So when we look, I'll back up and say one thing. When you've seen one EMS system, you've seen a total of one EMS system, right? Whether we're looking at Vermont,
there is no
New Hampshire, they all look different, right? There is no one answer, and there's no necessarily one right answer. One of the things that's unique about Vermont EMS is that for such a small state with such a small population, we actually have a very high number of services, right? We have one EMS service for about every 8,000 people. And that makes us a little unique in that, one of the challenges with that is that the majority of our services have a difficult time finding an economy of scale that allows them to operate financially viably, that allows them to operate, efficiently and be able to handle the vast majority of their own call volume. So we are unique in those circumstances. It doesn't mean it's wrong. It just means that, we're just one EMS system and we're no different than when you look at everybody else. When we do look at across the country, what we do see though, in many areas is as the smaller EMS services have found it more and more difficult to maintain staffing, as they've found it more and more difficult to remain financially viable. What we have seen is the creation of medium to large size regional services. And that's where you essentially cross the threshold where you have a volume of both 911 response, interfacility transfers, contracts with existing healthcare institutions, that you have an economy of scale that you can support the system. It's that you can support a regional system that in many cases have a very far reach and tremendous capabilities. And I would say, while we do have, close to 180 total services in the state of Vermont, I think we also have a few good examples of the success that a regional EMS service can have here in Vermont. And, I would refer you back to Chief Hazelton and the work that Rescue Inc. has done for the last 50 plus years in the Brattleboro region. That is an example of a highly efficient, highly capable regional EMS system that can do so much more than just provide 911 response, and they can do it in a very highly efficient and economical way. So I think there are Vermont examples that we can look to that demonstrate where we as Vermonters have found success in doing this.
Hold on one second. All right, thank you.
Follow up very quick.
Very quick.
I just want to know if there's one state that you think does it well. I'm just curious. You said there were other states. If you had one, and if there's not, that's great. I don't want to spend any time on it, but if
I'll just answer quickly. I don't think you can answer it state by state. I think you can, we would need to bore down to more regions or counties. It looks all, are there other examples out there? Absolutely. But it would be difficult to classify that by state.
Okay, I want to give Mari a chance, but then we really need to give our next witness enough time. So Mari, hopefully this can be a bit short.
Thank you. So I want to go back to clarify what Representative Houghton and I think we're focused on the same issue of accessibility to funding, and not every EMS is incorporated into town or municipal government. And we know we have a lot of volunteer organizations, and over the years, last few years in this committee, we've heard testimony multiple times that that the application process was onerous enough for volunteer groups, that was a barrier. And I know you spoke to that. I know also that there was a time when the $150,000 annually was not making it to Vermont EMS services. And there was actually at one point about $450,000 still in the special fund that hadn't been dispersed. So I still have that concern, and I want you to verify that what I think I heard you say was that there are no longer administrative barriers like that, or like there have been in the past for smaller organizations that don't have administrative help to apply for these funds. Is that what you're saying? There's like those barriers are removed, and those small volunteer groups can access that funding.
So just to set the record straight, so the way the EMS Special Fund has been administrated is that those funds are made available. That $150,000 is divided up amongst the 13 EMS districts, and every EMS district chooses to or not submit for a grant to receive those dollars. The statute speaks clearly as to what the special fund can be utilized to support, and much of that centers around EMS education opportunities. Historically, not every EMS district has chosen to apply for a grant. And I think to your point, Representative, because many of our EMS districts are entirely, again, volunteer organizations that have little to no administrative help, they may not have a bank account, right? They may not have taken those steps that are necessary to be able to enter into a grant agreement with the Department of Health. So if we think about the special fund historically, for those EMS districts that have not taken the steps necessary to meet the grant requirements, the barrier of accessing those dollars still exists today. But we also know other EMS districts have taken those steps. So when we talk about the challenge of districts accessing those dollars, it really comes down to the local capability of an EMS district to be able to meet the state's requirement around grants, and whether or not they have taken the steps necessary to be able to do so. Some districts have taken the steps to do that, and other districts have decided not to take the steps to do that.
So it sounds like there still is a capacity issue and it's a barrier.
To get to your point, the requirements around applying for a grant with the state still represents a barrier for some for some EMS districts. What we have done, and as I've described, is through taking those unallocated dollars and injecting it into the education system to remove the barrier of cost. Essentially, we've made every single one of those dollars now accessible to every EMS practitioner, every EMS service across the state. And when we implemented that program in June, every single licensed EMS service essentially had a credit with the health department, and they could select from essentially a menu. They could say, you know what, we're going to utilize our money that's allocated to us, and we'd like to send 2 people to advanced EMT training. And they would just apply for a voucher with us, which essentially was just filling out an online form, and their folks would go off to training and receive that at no cost.
Okay.
So I'm going to need to.
Very much. I think I've gotten my question answered.
Okay.
Yeah, and I would just sorry, Will, but we need to move to the next. And I just want to say that this is starred on my piece of paper. We will be coming back to this issue without a doubt. We need to look at our statute and make this easier for everyone to gain access to. So thank you. And we're going to bring up, and I'm sorry, I'm going to pronounce your name wrong. So I'm going to let you.
Really?
Really?
Sound it out.
Gwen
Zakov.
Welcome, and thank you for waiting so long.
No. My name is Gwen Zakov. I represent the Vermont League of Cities and Towns, and I've been in this building on and off for probably 15 years. Toppers was here when I was a second assistant clerk in the House. This is the first time I've been in this committee when to testify.
Welcome.
So, it's exciting to be here. and in the old appropriation room.
Yeah, it's kind of fun, isn't it?
So the testimony that came before me was fantastic, and it's always wonderful when you go last because they sometimes hit a lot of the highlights you wanted to touch upon, so it makes it a little bit easier for you. But to do a little table setting here, I just want to say, the Vermont League of Cities and Towns, we represent all the cities and towns in the state of Vermont, all 247, with the addition of the new city of.
Thank you for recognizing that.
Essex. And we represent, obviously, because we represent all the towns and cities, we represent towns and cities that have create this patchwork that we've been talking about right now. And we have towns and cities that have their own embedded EMS in their communities. We have towns and cities that have their embedded EMS through their fire service. We have towns and cities that have no EMS at the local level, that contract out. They might contract out with another municipality. They might contract out with a nonprofit. I mean, it runs the gamut. And what's really interesting, which is also very exciting being in the House Healthcare Committee, is that one of the frustrations, because I follow a lot of public safety issues, is one of the frustrations I've always recognized is that EMS is always housed in government operations when it never made sense to me because it's such a key component of the healthcare system. So I'm hoping that this is sort of what's happening now this year, having EMS services in this room. It will continue forward because I honestly don't think that the Government Operations Committee is necessarily the best place to house a lot of these issues. It's just a very distinct and separate system. Thank you for listening to all these issues. Obviously, I wish Representative Sims was here. She reached out to VLCT over the summer last year, convened a working group, which is sort of where that bill came, or the bill before you came from. And we became sort of the catalyst of the, making the synapses fire and connecting the right people. And it's really important to remember that EMS right now, they don't have anyone in this building advocating for them. I represent the towns and cities. I don't advocate for EMS. I'm just here sort of speaking on behalf of the communities because, the municipalities provide the service because the state doesn't provide the service, similar to fire, a little dissimilar to law enforcement because you do have state and law enforcement power that deal with the same probably call volumes that EMS provides, but there's no backstop. There's nothing at the state level that's providing these services. It's all left to the local communities to figure out. And most recently, I've been on the EMS advisory committee for quite a while, representing the Vermont League of Cities and Towns. And it's just, I think what's important to talk about in terms of the study committee that's in this bill, I think it's really, 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 really important. What really excites me about that is that there's money for a consultant in this, because another frustration you have, I love study committees as much as the next person, but if you have the same people at the table trying to solve the same problems they've been tasked to solve over and over again, perhaps they're not coming up to a solution because they don't have the resources available to solve some of those problems. That happens a lot in the dispatch discussions that have been going on for quite some time and coming to a head this session as well. And so we strongly support that study committee. We strongly support the entire bill. We see it as sort of like a first step in the process, and finally having some momentum on this is really, really exciting. I think the more you dial, I think it has to be a step-by-step process walking through solving some of these problems because it is such a patchwork. And we really need to start understanding how to create a regionalized system, because that's really the only way out of this. Right now we have a regionalized system that doesn't make any sense. We need to create a regionalized system in a step-by-step process that works leading into the future, because as was said before, we have a system that's antiquated, that was built in the 70s, is based off a model that it doesn't work. And as you said, in Essex, we have communities. I have a lot of town managers and a lot of select board members who are coming to us saying, how are you going to solve this problem? We have requests coming in from our nonprofits and from our departments asking for 50% increases, 100% increases. We don't have the capacity on the property tax to keep doing this in years moving forward. And I always say this, like a broken record, local government, we have the property tax. That's it. There are a handful of towns that have a local option tax, but that is about 4% of the communities out there. we have the property tax, and with the continued pressure on the education property tax, we're even more constrained. So if you're asking the local budgets to solve the gaps between where reimbursement rates are falling short, it's not going to happen moving forward. The cost is just growing and growing, and the capacity at the local level is not there. And that also speaks to sort of the geographic inequities that was referenced earlier, is that the way the system is, you have a large state. You have really rural areas where the grand list size and the taxing capacity at the local level is never going to meet the demand of what the services that are needed at the local level are. There's just no economy of scale right there. And so that's a key thing to remember, because if you can't do it at the local level, the state has to step in, because there's no one else coming there to save the day. So we see this as a first step in a partnership. Again, that consultant piece is right. I keep going in on that because I think that's what really needs to happen. We need to have some data. We need to have data. This is happening in law enforcement already. They've had the resources put into it. It needs to start happening with EMS. It's at a really critical stage. And, I'm glad to hear that there's so much money being embedded in the budget, but I'm going back to what was just said about the training. I think, and I'm happy that you flagged that issue, because I think you need to dial, and I say this because we've been dealing with the ARPA money coming to local governments over the last 2 years. And we had to partner with the legislature to get money to Vermont League of Cities and Towns to help communities walk through the process. And initially we were thinking we're going to help towns that have populations 400, populations 600, populations, or communities that had a select board of 3, town manager, administrator. What we're recognizing is that all size communities need help. It doesn't really matter what size, they all need help. And we need something similar for EMS at this stage. We need to have something where, we need to get money out there. We need to figure out how to get it on the ground. We can't be putting $150,000 in a budget every year and not get it to the people that need it most. That's unacceptable. We need to make it easier, not harder. So I'll end with that. Just again, really excited to be here. And I'm so excited that this committee is taking this issue seriously, because I don't think you could wait another year to at least get the ball rolling on this.
Thank you. And I think back to the issue with the training, I'm just going to put it out there. I'm open to suggestions for those of you who know it well. So, and we will have someone walk us through the statute at some point to make sure we understand what the process is today, but open to suggestions. Go ahead, Drew.
So just for information, out of the 13 districts last year, 4 were able to get through the hoops in order to get the money. So that can illustrate how difficult that process can be.
Yeah.
And unfortunately, one of those challenges is the district has to buy insurance in order to be eligible for the grant. So a large chunk of the $150,000, actually 15-20% of it, is going to insurance policies in order to be eligible for the grant. So, as we're digging into that, that money doesn't go nearly as far as you think it does.
Yeah, no, it doesn't sound like it. So, okay. Yeah. More other questions for Gwen?
The smart people came before me.
No, unfortunately, after a while, we just.
I'm at the 30,000, 40,000.
Sorry, we already know what we want to do. Some of us anyway.
But you had Drew here, and Drew's phenomenal. And I will say, going back to the whole, they don't have a representative in this building that necessarily advocates them. If we didn't have Drew, we as the state didn't have Drew volunteering his time and energy to provide these resources, we wouldn't be here right now. So
I'm just going to also throw out to the both of you, if there are other things that we're not addressing in this bill that you think need to come to the table, please let me know as well.
The only, I hate to put any criticism because I do love the bill, but I think the timeline for the report, I think it was pushed to December. I will say, having been part of that dispatching study group this past summer, it's a really tight timeline, so that might be something to consider. It's just
okay. Bobby?
I just have a quick question it's related to what Drew mentioned earlier about transporting between hospitals. I had a meeting with the CEO of MVRH, Sean Tester, and he told me that because some hospitals are over capacity, there have been cases where they've had to take somebody from St. Johnsbury all the way to Albany.
Oh, he's got better cases.
Yeah, those, I'm sure that, but so how do we address that? Because that means an entire ambulance is out of commission basically for the whole day.
So what you probably didn't hear is that when the ambulance arrived in Albany, Albany has we call it 2-hour wall time. So when they arrive, they're put into a queue and it takes 2 hours to get the patient transferred over. So we're not only seeing it out of NVRH, but every hospital in Vermont. In our area, we're going to Southern Connecticut every single day, Manhattan, Boston, because our local hospitals, again, in order to get those specialized services, our local hospitals don't have the capacity.
So it's a hospital capacity issue as much as it is an ambulance, like time consumption thing. Yeah.
Well, and that creates a backup. So when that ambulance now is going 8 or 9 hours round trip in order to take one patient, it backs up the other two that should have been able to be moved in the same amount of time. So that kind of spiraling challenge of hospital workforce, hospital capacity, ambulance resource, it's just compounding itself.
Yeah. That was bigger than just the ambulance issue. We have to address the other parts of it too. Okay, I just wanted to ask about that because it just shocks me too, all these things that I've heard. So.
I mean, as Brian said earlier, we operate in such silos and we really have to stop when it comes to healthcare. And I think we're getting there, right? We're doing better, but it's still an issue.
Just a statement. The duties of that commission or committee that's being set up, one of them is not showing people in those rural districts how to get through that maze. I would think that would be something that would be a priority.
And I will say the study again is in the budget right now. If we move forward with the bill, I would also suggest that we keep the study in the bill as well. So we have it both places in case it gets taken out of the budget at some point in the process. So it kind of gives us coverage there. Leslie?
So I know you're probably discuss if we want to go forward and we've got a few minutes, but I'm just wondering if we do go forward, could we hear from federal people? And, to look at the Medicare piece and see if there's any kind of pressure influence, I doubt it, but you never know, to at least have it on the record.
Brian?
I was waiting until I came in here so it wouldn't be awkward on Zoom. I'm pushing it right now, but I'm going to do it. Just like a trigger warning. Like, this kind of goes beyond the scope of the bill a little bit, but like we were talking about federal level. We're talking about like how to fund things like more sustainably. Might we be wanting to have a discussion about that on a bigger level? Like universal healthcare, I said it. That's all. Okay, so
we're talking about EMS.
I know, but if we had universal healthcare, then they, like the EMS providers would just be paid. And like, we would give them the medicine and they could just give it to people and you're not thinking, oh, we're going to lose money. You're just doing what you have to do, but we should just be like, do what you have to do. You're not going to lose money, and the other thing is, about the prescription drug redistribution. I almost said suppository, which is not the word. It's a repository, right?
Repository.
Yeah, I know. It's the opposite. It's like the opposite. Sorry. But the nurse came on camera laughing. Right? She's like, I know about those. What I'm saying is that the prescription drug redistribution, another thing is why can't, we mentioned earlier, EMS using those, but they're EMS and all other providers, we should be telling people about it every chance we get too, so there's one thing is sustainably funding it. And the other thing is not wasting things anymore. I just feel like these are two themes.
Right. Absolutely. Okay. And I hope the drug repository, unused drug repository bill goes through because I do think it's an important piece of our, process here, but let's stick to EMS for now. Art?
Yeah. One thing that strikes me about all of this, and always strikes me in healthcare and a lot of things we do around here, is the disorganization. And with that, I'm wondering if administration can be centralized. And I don't know, you know more certainly about this, but can we get a centralized administration, and then maybe it is already, I don't know, and then spokes out to the various EMS things, and maybe save money that way.
Well, I don't have the study language in front of me, but I mean, I think part of the study is looking at how we regionalize and make things more efficient. So
Yeah,
study goes through.
it's gonna be, I haven't read the bill, I'm just picking it up as we go here.
That's a good point.
I think that if we ignore that, we're wasting money in my mind.
Right. It's always the balance between local control and not local control.
Well,
I'll say for the record, for the League of Cities and Towns, we have our 2-year legislative policy. I should have said this in the beginning, is that VLCT supports any incentives, any leaning into creating a regionalized public safety network. I think, that's kind of the one recognition I think that we're seeing at the local level, is because we already have this weird organic ad hoc regionalized, it's not really regionalized, but sort of like kind of you figure it out as you go kind of system. And not every town is going to have, it's maybe bigger towns will have their own fire, police, EMS, but that's very rare in this state. So there's our voting members, every town has a vote at the league, and they have said resoundingly for at least the last 10 years since I've been doing this work, that this, as we partner forward, we need to be moving towards a regionalized model. And that's not like loss of local control, because I think if you talk to Drew Hazelton and the way he has his board, it's, 1 vote per town. We have that at the Regional Planning Commission level. There are ways of going about these things. Towns have been trying to do it with dispatch in different areas, but it takes time and effort based off of what's written in statute when you have intermunicipal agreements and towns saying kumbaya and things. But all it takes is that one coming out of the gate who does it properly that becomes the model for everybody else. And I think that might be part of the answer, but we really need to get the data first, and we really need to see where things are and get a lay of the land before we even start solving the problem. So, and we've done that with other services. We just haven't done that with EMS yet.
And that's the study you're referencing.
Exactly.
Data. Okay, great. Thank you.
You're welcome. Thank you so much.
All right, good conversation. Thanks to everyone for being here, and we are done, so we can go off air.
So where are we going? What do we do?
We're not having that conversation right now because we've been sitting here a long time. So we'll have a committee discussion when we can fit it in, but it's almost 12.